At the end of the day, the #1 priority for a healthcare overhaul should be the cost, bringing down healthcare costs. Here to explain how healthcare legislation could go through without passing the buck to you, the taxpayer, is Guy Sansone, Managing Director of Alvarez & Marshall. Mr. Sansone is also the head of the firm's healthcare industry group, and he used to run a hospital, so you've seen it on the front lines. Guy, thanks so much for being here.
Thank you.
You have 3 ideas on how to cut costs in healthcare, which should be priority #1 rather than potentially insuring everybody who's uninsured in this country. The first thing that you talk about is closing or at least merging underperforming hospitals. Is the government essentially pouring Medicare money into hospitals that are losers?
Well, I think what's happening here is we're developing a healthcare overhaul plan that is not addressing the root causes of healthcare today, which is the underlying rising costs. And one of the areas where the government, insurance companies, payers, private pay, spend tons of money is in underperforming hospitals. Hospitals with less than 150 beds, hospitals with admissions of less than 50%. Our firm recently did a study that shows there's over 700 insolvent hospitals in this country. 700 out of 4,400.
You're simply saying treat hospitals like another type of business. A restaurant would not live if it was only 50% occupied at any given time.
Correct.
They need Friday, they need to be full once in a while. Some of these hospitals sound like they're never full. You say treat them like a regular business and shut them down and consolidate.
They are treated like a regular
But that's
business.
politically very hard to do.
Very difficult.
We're closing your hospital. Sorry, poor Kevin.
Why do they exist? Why do they exist if they're losers, money losers?
Because we don't treat healthcare like other businesses, right?
Well, healthcare's changed over the last 15 years, okay? You've seen tons of money allocated to the outpatient setting. Home health, home hospice, nursing homes, outpatient rehab, outpatient clinics. Yet at the same point in time, you just haven't seen the decline in monies allocated by the government, by insurance companies, to hospitals. So your census, your people staying in hospitals has gone down. The fixed cost of hospitals continues to go up, and those hospitals can't survive on their own. And now what's happening is Medicare, for example, based on our estimation, if you close 200 hospitals, you could free up $10 billion of Medicare dollars on an annual basis that could be reallocated inside the system and thus be used to provide, health care for the underprivileged and the uninsured.
Your second idea is that healthcare dollars are essentially being misspent, doctors over-testing because they're worried about getting sued. So implement tort reform is your second idea.
Tort reform has been around forever. This country, if you go to some of the actuary studies, spends anywhere from $35 to $40 billion in medical malpractice premiums on an annual basis. Tort reform has been successful in states like Texas. You don't see that done on a national basis. It needs to be done by state on a national basis. If you could bring down tort costs 30%, again, more money's freed up in the system.
Guy, why didn't that happen, though, with Republicans running the White House and Congress? Why hadn't it happened?
Tort lobby is extremely powerful.
The tort lobby...
Because a lot of lawmakers, whether they're Democrats or Republicans, are ex-lawyers.
It's extremely powerful.
Right. Right. But it's something that seems obvious to the layperson that runs hospitals, because every year your cost of defending sometimes frivolous litigation is going up and up and up. It's not dollars that are spent on patient care.
We know that costs have gone up for everybody that works and has employer care because of the high percentage of people that are not covered, right? So they go in, they get work done at a hospital, it's not paid for, and so that lifts premiums for everybody else. That's the president's point. And he's right about that, right?
He is right about that.
How do we solve that problem, though? Because even if you give everybody coverage, and what's interesting to me is that we seem to have gotten off this discussion about what insurance really is, right? It's like I have fire insurance, but I don't go around setting my house on fire just because I do. I've never filed an auto insurance claim in 21 years of driving. It's a hedge against risk. So to my point is, how do we change the dialogue to say, if you're talking about just giving people all the health care they want, why wouldn't they just go to the hospital all the time and raise prices? Because they're simply accessing more of the goods and services.
Well, you're saying two different things there. The problem is that we're looking at creating a nationalized insurance program. And this insurance program is going to pay hospitals for those people that were uninsured or underinsured. Now, from my perspective,
But aren't we already paying for them?
Excuse me?
They're already being paid for.
They're already being paid for.
So, okay, do you see? Maybe I'm not making myself clear.
Right.
They're already being paid for by somebody. Dagan and I and you and people that have a job with employer-provided health care, our premiums are higher because we're covering the uninsured.
Right.
So what's the difference in changing where the money comes from? Aren't you just moving shells?
Effectively, you are, yeah.
But is the danger in that if you have a public plan or government-run plan, their reimbursement rates to the providers, which the hospitals already experience, will be lower, and if you try to preserve private health insurance, then the cost will just ultimately be passed upon to the people who still have private insurance? That's
a great point. This is called cost shift, and that cost shift is something that both hospitals fear and both people that pay for insurance fear, because that cost shift is also going to change what's going on in hospitals today. All of a sudden, hospitals are going to have a different type of payer. They're going to have a lower mix of payment revenue coming in, and that's going to, again, if you don't solve your cost problem, it's going to continue to provide pressures on those individual hospitals.
Your last thing is level the playing field for HMOs. What do you mean by that?
By our analysis, hospitals, and that's a $700 billion industry, right?
A lot of jobs in healthcare. One in every 10 jobs in America is in or around healthcare.
Correct. $700 billion of revenue. Hospitals spend somewhere between 6 and 7% annually on billing and collections. Now, is that billing and collections of billing Medicare? No. Hospital gets your Medicare check every 2 weeks. Every 2 weeks on a prospective payment basis, that money's coming in. The 7%, or by our estimates, over $40 billion a year, is primarily being spent on managing your contractual arrangements with managed care providers. And managed care providers are incentivized to deny your claims. They're incentivized to push back and not pay you because, A, they're profitable entities themselves. Okay. And so if you create both legislation and manage the contractual obligations of those institutions and come up with financial or technological ways of paying hospitals and providers on a more current basis, it again brings more liquidity into the system.
Guy, good to see you. Guy Sansone, former head of a hospital here in New York City and now head of the healthcare industry group at Alvarez & Marshall. Come back.
Thank you.
I hope you're right, because you think about paying for stuff all the time, and it's like if my car insurance covered oil changes and new tires, the car would be in the shop all the time. Getting upgraded. Guy, thank you. All right, Cash for Clunkers, the chairman.